Okay. Well, welcome everyone. We are so very delighted to be here April 21st for this excellent presentation of Dr. Mittman. And we know that there are many of you on the Zoom. And so what we would like as a housekeeping component is that if you have questions, if you want to chat them into the Zoom, and then when we're open for dialogue, please be open to unmuting and kind of sharing in the dialogue space. So we're here for conversations to ignite the advancement of implementation science. And it's a very topical for us here in Cleveland, as we in our Clinical Translational Science Collaborative are attempting to spread implementation science knowledge, competencies, and awareness in our research as we move forward in our advancements of science. And so today I would like to introduce, we are very honored also to have Dr. Kurt Stange here as moderator of this session. Dr. Stange is a family and public health physician and longtime CWRU faculty. He's been doing implementation science research since before it had a name, which I found that was very, very interesting. So with that, Dr. Stange.
Thanks, Dr. Dolansky. I really like this title, Conversations to Ignite the Advancement of Implementation Science, because that's what Brian Mittman's been doing through his whole career. As the field grew, he was there helping to nurture it along. He and I first met at a conference that neither one of us remembers quite what it was about, but it was a small invitational conference in Chapel Hill put on by Russ Glasgow and Larry Green. And I think it was looking at the issue of external validity, how so much of our science is about getting things right narrowly. And then we say, and then you're just supposed to, make it happen in the real world. And so it was starting to work on that. And when there was a new United Studies section, the field started to have a name, and Brian launched this new journal. It really gave the field a way that it could come together and start to coalesce. So he really has nurtured this field along as it's developed. He's a senior research scientist at Kaiser Permanente of Southern California. He has appointments at UCLA and Rand, works with the CTSC there, and all these things are really about implementation science and improvement science. He serves on the methodology committee for PCORI, which has really, again, been very influential in setting the stage and framing the methods for how we do research, because a lot of the methods, the traditional methods, don't really work very well for implementation science and patient-centered outcomes research. So we're really honored to have him here. Mary and I are going to be monitoring the chat. So if you have questions or comments along the way, put them in along the way, and we'll try to synthesize those for the discussion. So thanks very much for being here tonight, Dr. Mittman.
What I didn't do is make sure I know which of the devices I should be using. Okay. Do. So first of all, thank you to Mary for organizing the session, to Kurt for the kind introduction, to others for joining, Dave Aaron, who I haven't seen for a number of years, who handed me a set of slides from a talk I gave in 2002 that unfortunately has some of the same themes. So as I'll discuss, we've been knocking our heads against the wall for quite some time and making some progress, but not quite enough. So my hope is that I can stimulate some additional interest in some of these issues and some of the challenges. Just a quick comment on the title, which is my version of the arguments that are in the article that I hope all of you had a chance to look at. Basically, the idea that our field of implementation science was founded on the criticism of our clinical research colleagues who publish in journals and walk away with the assumption that if you build it, they will come, that publishing research is enough for it to be acted upon. Unfortunately, we tend to do some of the same, that we often will publish our findings. We will document our success in achieving improvement or implementation in a study. We describe the approach that we used. We never describe enough of the details that can actually be replicated, but we don't take the time to follow up. So the theme of the set of remarks that I'll offer is how to improve our value, improve the follow through, and ensure that the insights and the evidence and the findings that we develop actually achieve some impact. What I'd like to do is, I suppose, a bit of an experiment, and that is, in order to ignite the conversation, I'm going to go through a very long series of issues and challenges and problems, offer some solutions, without going into any real depth in any of them. And the hope is that all of you will find at least one or two that might be intriguing. And we can begin to discuss those during the Q&A discussion session. And I would hope that some of you would follow up with me afterwards to talk further about any issues that do interest you. So
Keep going.
Just make sure that I'm looking at the right place at the right time. And I know that those of you who are joining via Zoom will offer comments in the chat if I'm not loud enough or if you can't see me. So the first slide is basically one of the key challenges we face in the fields of implementation improvement. Basically, it's hard. And the kinds of barriers that we face are multiple. In addition to equating the challenge of implementation as this gentleman trying to push a heavy rock up a steep hill, we should be thinking about all of the unseen ropes and bars and chains that are holding that boulder in place. And the problem with a lot of our work in this area is that we tend to address one or two of those ropes or bars or chains and eliminate some of the constraints, but not enough for us to move the boulder. So the need for multi-level, multi-stakeholder, multi-component approaches is one of the key challenges to implementation. And it's one that our research methods and approaches aren't set up to handle very well. We like to study, for example, vaccines, which are single, simple interventions, very homogeneous, fixed. Everybody gets the same intervention. And the mechanisms of effect and the outcomes are relatively simple and straightforward. So as researchers, studying the effectiveness of the vaccine is very straightforward. Studying implementation barriers and phenomena and evaluating implementation bundles is the opposite end of the continuum. And the fact that there's so many levels nested within each other that represent barriers and factors that influence our behaviors of interest, again, it is part of the challenge. So we know that because of the multiple barriers, we need multiple solutions. And there are many frameworks, as you know, in the field of implementation science, most of which are not very practical. So in terms of the theme of making our work more usable for policy practice audiences, giving them the CFR list, the CFR diagram, as important as it is, and one of the co-authors is sitting in the room here, again, it is designed by and for the research audience. And we need to think about developing checklists and simple guides for practitioners who wish to implement to allow them to deal with the multiple bars and ropes and chains. So that's one of our challenges. In terms of research, I'd like to quickly go through this framework of 3 different generations of research, and as with many other comments, not spend enough time talking about it. But basically, if we think about our prototypical vaccine study, in most of the research that's been done by faculty in med schools and pharma companies and so on, I would label that generation 1 research. Very simple, very straightforward. Beginning a few years ago, we realized that evidence-based medicine should be based not only on FDA trials that tell us on average whether something is effective, but on patient characteristics and a number of other factors. So personalizing the evidence and understanding not whether a specific clinical intervention is effective on average, and therefore should be FDA approved and used, but instead how to use that evidence for individual patients is what I would label generation 2 research. Excuse me. The work that we do as implementation scientists, and this is true of healthcare delivery science in general, health promotion researchers, other forms of behavioral, social kinds of research, is in my view a separate generation altogether. This is research that guides decisions for which the interventions are not simple and homogeneous, for which the settings and the contexts are highly heterogeneous and changing all the time. And it's just orders of magnitude more complicated. So we need to think about different approaches to research because the typical research designs and methods that work well for vaccines don't work at all for these kinds of phenomena. So let me walk through a set of comments on this theme and then move to the next theme in the collection. So when we think about generation one research, again, a prototypical vaccine study, very simple question that we as researchers face: is it effective? Do the benefits outweigh the harms? And if so, should the FDA approve it? Should it be added to the formulary? And even for frontline practicing clinicians, should I prescribe this medication? Is it effective? Yes or no? We know how to do this kind of research, and we do it well, we do it all the time, and it's quite useful. When we deal with complex health interventions, though, health promotion programs, implementation, improvement strategies, if you were to ask the question, is this intervention or this improvement strategy effective? You rarely, if ever, get a yes/no answer. The answer is always sometimes or it depends. So again, the simple kinds of generation one study designs and methods just don't work very well. So the concept of complex health intervention, something that I worked on as a member of the methodology committee, one minor update, and that is I rotated off a couple of years ago, so I'm no longer an active member of the methodology committee, although I maintain a lot of interest in what they do. But the concept of complex health interventions is very useful in distinguishing between the phenomenon that we study as opposed to our clinical research colleagues. And there isn't a widely accepted consensus definition, but this slide indicates some of the key features that distinguish complex health interventions from simple interventions. And again, when we ask the question, is a complex health intervention, a health promotion program, healthcare delivery innovation, is it effective? The answer is almost never yes or no. It's sometimes, and it depends. Now, some of our colleagues have made the argument that many of the clinical studies that we rely on in evidence-based medicine show an effect size of the drug or the vaccine of 3, 5, 7%. And so that when we see an average pooled effect size estimate for audit and feedback, for example, from some of the systematic reviews, the Cochrane reviews, that should be good enough. There's a flaw in that argument, though, and that is if you can't tell who is going to benefit from the vaccine, and you know that 7 to 10% of patients will benefit, and there are very few harms, if any, and very low cost to prescribing the vaccine to everyone, you just go ahead. If you know that only 5, 7, 10% of your VA medical centers will benefit from a quality improvement package, it doesn't make sense to say everybody should implement that package for a number of reasons. First of all, the costs are very high. So the harms significantly outweigh the benefits for all of those other settings. Second of all, we have a unique ability with complex health interventions to modify and adapt them and tailor them. So if we can adapt, we should adapt. Now, let me illustrate the challenge of complex health interventions is this idea that the answer to the question, is it effective, is almost always sometimes or it depends. I don't know that any of us who've ever conducted implementation improvement science have seen this sort of pattern of results where the intervention sites show significant improvement in this case, levels of adherence to a guideline versus the usual care sites. And my apologies for the formatting. They didn't translate very well to this computer. But this basically shows you, obviously, no overlap at all between intervention and control. What we tend to see for complex health interventions is almost complete overlap. And the idea that some of the intervention sites end up on the far left side of this continuum of the distribution, showing significant harm, just as many of the usual care sites end up on the right-hand side. So the question here that we should be asking is not, is this intervention effective? Even if there is a very small intervention control difference in the average effect sizes, doesn't do policy practice leaders any good. The question we should be asking is who did well and who did not, why and why not, but most importantly, what can we do to shift everyone off to the right? And that directs our attention not to average effects, but instead to adaptation mechanisms of effect. And it again guides us to focus on adaptation and tailoring. So rather than what we do as good gold standard clinical researchers, which is we suppress adaptations in order to achieve high levels of internal validity and fidelity, We should be embracing adaptation. We should be studying it and understanding it, and ultimately we should be guiding it. Because we have the ability to tailor, we should take advantage of that ability, and we should guide the tailoring. So it's a different sort of purpose for the research that we do. So one of the key tools that allows us to explicitly study and deal with adaptation and essentially have it both ways, which is to have the ability to adapt and tailor, but also to achieve internal validity, is this core function form framework that Penelope Hall introduced a number of years ago, and for quite some time actually sat with relatively little use. A group of us in the Corey Methodology Committee took that framework and began to further develop and elaborate it. Monica Perez-Yoles, who's now at the University of Colorado, did some work with me to provide more of a set of practical recommendations and guidance for using the framework. But the basic idea is for us to not worry too much about the details of operationalization when we conduct research. If I'm interested in educating patients, or if I'm interested in physical activity as part of my intervention, it's not quite as important for me, and I should not specify 20 minutes of walking 3 times a week. I should specify 20 minutes of physical activity. So the idea is to recognize the need for tailoring and adaptation, identify what are the core underlying functions of our intervention activities, not develop manualized interventions, not try to achieve strict fidelity to a protocol, but instead understand what we're trying to achieve. And the question is how to achieve that goal is one where there should be lots of adaptation and tailoring, lots of flexibility. So again, sort of in a hit and run mode without going into too much detail, recognizing and using the core function form framework and thinking about our interventions, not in terms of manualized interventions and strict fidelity, but instead underlying principles and underlying functions is one of the solutions to make our work more practically useful. So the point that I made earlier, I'll repeat just briefly, and that is the fact that when we conduct research on complex health interventions, like implementation improvement bundles, like health promotion programs, we should not be focused on answering the question, is it effective? We need to be focusing on mechanisms of effect and understanding how those interventions achieve their effects and where along the causal pathway we can intervene in order to modify outcomes. You know, the image that works for me in thinking about this is the mousetrap game that I understand is still sold, but it was one of my favorites as a kid back in the 60s. And the basic idea that typical clinical research is equivalent to watching the first step in the mousetrap where you drop the marble and then running to the end to see if the trap falls or not. Setting up your 1,000 dominoes and flipping the first one and going to the end to watch the last. If we conduct research where we're only looking at the inputs and the outputs, we have no way of knowing what went wrong. And for me, at least invariably, something went wrong and I had to tweak one of the little parts of the contraption. Studying complex health interventions and their mechanisms of effect and understanding what happens inside the black box is how we identify the points along that complex multi-chain causal chain, multi-link causal chain. That's how we understand where we need to insert tweaks and refine things. So again, it's a different focus of research. The focus is on understanding mechanisms and on guiding adaptation, not measuring impacts and reaching a yes/no answer to the question. And again, with an emphasis on modification, adaptation, tailoring. So, you know, again, that's sort of the first main point that I'd like to convey, and that is, as we think about our research, we should move ourselves as far away as possible from the mindset of clinical trials of simple interventions. Clinical trials are useful. We need to randomize. We need to use a lot of the same methods that are relevant for vaccines, but we need much more than that in the work that we do. So if we think more broadly about the issue of value and relevance of our research, what are some of the methods that are published and what are some of the responses to the Betis article, the pre-mortem article, ways of ensuring that what we do has more relevance and value for policy and practice purposes? And when you think about the translational pipeline, we start from the far left side in basic science. A basic scientist has one primary role and responsibility, and that is learn something new about the world. eventually whatever that scientist learns is likely to yield some benefits to society, but it's not their job. They don't need to worry much about how their findings will be used. Clinical researchers, translational scientists in the middle have to worry a little bit about ultimate impact. But on the far right-hand side of the pipeline, the implementation scientists who are responsible for taking all of that knowledge and that content and making it useful, our focus should be very directly on the needs of decision makers, the frontline clinicians, the practice leaders, the policy makers. And again, these are some of the kinds of changes in the way that we go about doing our work that will allow that to happen more effectively, more reliably. First of all, implementation research, improvement research should rarely, if ever, be conducted by academic researchers who are not tightly integrated into a health system. As a VA researcher, and now as a researcher within Kaiser Permanente, I've always had the advantage of working in a living, breathing health system with a living lab. Practice-based research networks, other forms of embedded research are available for university-based researchers. But the point is that we should be conducting our research essentially side by side with practice leaders. And that's especially important for implementation research, where many of the influences on clinician practices are not merely their knowledge or the reminders that we may deploy, but instead leadership needs and motivation and advocacy, organizational culture, and other factors. So if we're trying to implement and change practice in one direction, but the leaders and the health system are moving in another direction, we know who's likely to win out at the end of the day. So ensuring that we are conducting our research in a fully partnered, stakeholder engaged, and embedded manner is one of the absolute requirements for policy relevant, practice relevant research. The idea that we need to take an all of the above or kitchen sink approach is something that sort of disturbs us as researchers. We like to identify the active ingredients, to identify the 1, 2, or 3 elements of our multi-component intervention that are likely to be effective. What if you can't see any effects, though, until you get to 10, 15, 20 elements? So if we think about 2 ways of trying to get to that optimal package of intervention components, what we tend to do is start with 1 or 2, don't see much effectiveness, so we add another. Or what's more often the case, we move to a different area of research where it's an easier problem. But if we were fulfilling our responsibilities, we would continue to add intervention components until we see some effect. My argument is, let's try it the other way around. Let's throw everything at the problem, see if we can get an effect, which is, again, difficult to do and rarely seen. And then we can maybe think about trying to ratchet down a bit and identify the components that might be eliminated. The challenge, of course, is that's very expensive. It's very difficult to conduct the evaluation and try to tease apart the different components. My own view is that most of the components have not additive effects, but synergistic effects. So that if you eliminate one component, you're likely to see 0. If you're trying to get to 100 points of effect and you have 10 components and they have additive effects, each of which contributes 10 points, if you deploy 7 of them, you get to 70 points. Not too bad. But suppose the effects are not additive but multiplicative, in which case a 0 on any one of those components leads to a 0 overall. That's, I think, a more useful mindset to take when we think about multi-component interventions. And again, argues in favor of starting with the kitchen sink and then over time eliminating components. We tend to view external context, policy, regulation, financing, and so on as exogenous, and something that we just have to deal with or live with. But what if it turns out that the major influences on the practices that we are trying to change are actually those external factors? We need to view them as interventionable, if that's a word, something that we can actually influence. So thinking again about all of the different layers in the onion socioecological model and thinking about which of those different layers and categories of influences are most important and thinking about targeting those influences rather than assuming that some of them are given, in many cases, is the strategy for us to achieve benefit and show societal value. Let me skip down a little bit because I've discussed most of these and just go to the bottom topic. And that's one that I will talk about a little bit more when I get to coordination. But we have a challenge in studying complex health interventions that is a little bit different from the others that I've mentioned, the issues of adaptability and heterogeneity and so on. And that is the fact that our output is more complicated and difficult to use than is the case of our vaccine colleagues. Let's take the scenario of 5 studies that are conducted as part of a portfolio evaluating a vaccine. And those 5 investigators publish their work separately without any sort of coordination, without any real engagement of key decision makers. So no FDA decision makers, no insurance company representatives are on an advisory board for any of those vaccine studies. The 5 studies show relatively similar results. This vaccine is effective. They publish their results in different journals without any real coordination. It's not a bad scenario. The FDA decision makers, the insurance company leaders, and so on, they know what to do with those results. They can reconcile the differences across the 5 studies if there were any. And the information they need to make decisions is readily available from those study reports. Let's think about within VA, 5 researchers who are evaluating somewhat similar improvement strategies or implementation bundles. They all publish their results, and it's up to the VA decision makers to decide what to do with them. Those decision makers rarely, if ever, will have the ability to reconcile the differences, understand how the sites differed, how the interventions differed. We rarely see enough material published in the reports of those studies that you can actually replicate, let alone adopt the findings. And we also have the not invented here problem, where those decision makers reading a 3,500 word article presenting the results of the study are not likely to see what they need and to really have a good feel for the findings and what they mean and how to use them. So all of this, suggests that we do a few things better than we typically do. One of them is ensuring robust engagement. The not invented here problem, the idea that a study that was conducted in another set of sites where as a practice leader, I had no real involvement, I'm not nearly as likely to find those results relevant to me or credible, or for me to feel the level of comfort that I would need in order to act on those results. If, on the other hand, I was on an advisory board and I had a chance to watch the study evolve over time, I had a chance to weigh in on some of the intervention design features, some of the evaluation outcomes, I had a chance to see some of the preliminary findings and to help interpret them. All of that means that I have a much better, implicit understanding of what the intervention is all about. And I'm much more likely to feel comfortable implementing it, know how to implement it, and how perhaps to adapt it. So the basic idea is more and better engagement. But if we have 5 studies, you need coordinated engagement. Ideally, all 5 of those studies would work together to convene an advisory board that would sort of watch over all of the studies simultaneously. And that those 5 studies would report their results consistently. It's not enough to follow a consort reporting guideline in order to ensure that what you report is understandable by your target audience members, by the policy leaders and practice leaders. We need to make sure that we as investigators help to interpret and reconcile differences and explain and guide the use of our output. So again, a very brief summary of what is, a longer set of arguments, but that's again an item on the laundry list of ways in which we should be doing better to ensure that our work is useful. So let me go through very quickly 2 sets of slides talking about the learning health system concepts and then harmonization. And I know a lot of this will be familiar to you. So, if we look back over the amount of time that Dave, Kurt, and I, and others have been in this field, back to the period even before the word implementation science or quality improvement appeared anywhere. When I got started, it was always changing physician behavior, as if physicians were the only individuals whose decisions and practices we need to worry about. So this is a partial list of where we've been. My feeling about each of these approaches is they're quite valuable, but they're also quite limited. The goal of the field of implementation science is to facilitate more rapid, more reliable, better implementation of evidence. But that's not all that a health system needs to do in order to be a high-performing, highly effective health system. So again, the idea that each of these, for the most part, are useful but incomplete. To me, the concept of a learning health system is at least a little bit broader and encompasses more of the parts of healthcare delivery that we need to understand and strengthen in order to see high performance and outcomes. Although even the learning healthcare system concepts, as they've been published, tend to be somewhat incomplete. So here are some of the reasons why the learning healthcare system concepts are attractive to me. First of all, we know that, as I've said, individual health systems can't take evidence off the shelf and use it as is because of the need for the local adaptation of tailoring. So the idea that you are a learning, research-oriented health system, or an experimenting health system, perhaps, is a better concept to think about, allows us to ensure that the evidence that you're trying to implement actually works for you, because you're not just implementing blindly, but instead evaluating, refining, and following the rapid cycle iterative improvement approach that we know is a hallmark, a core feature of improvement science. So that's at least one of the reasons why health systems can't simply replicate what others do. They need to have some internal learning process and experimentation and evaluation. And there's some other features as well here that we can come back and talk about later on. But the work that I'm doing with a set of colleagues at Kaiser and elsewhere is taking the concepts of learning healthcare systems and trying to broaden them to the point where a health system leader can actually use that body of knowledge. If you talk to health system leaders who are familiar with the learning health system concepts, and if you talk to researchers as well who work in the area, I think for the most part, they would describe the current body of publications as very heavy on a sort of top level, which is broad statements of principles and vision and describing what a learning healthcare system would look like and what a wonderful world it would be if all health systems were active learners. We also have at the bottom of this sort of hierarchy, a lot of case study reports. NYU's rapid cycle iterative evaluation, Vanderbilt, Group Health Cooperative. There are a number of these case studies. And I would describe those as case study reports of partial learning health systems, because each of them describes one or two elements of a learning health system. What is missing from the published body of literature is what the IT folks call the middleware, the highly detailed, practical, operational blueprints that would tell me as a health system leader what I need to do. What are the capabilities, the capacities, the infrastructure that I need, and what are the activities that I need to have in place in order to function as a learning health system? And it's not just research and evaluation activity and expertise and capacity, but also some of the other items that are listed here. We need to have the ability to prioritize. So a group of us is working on the concept of a handbook to design and manage a learning healthcare system, trying to identify all of these capabilities, the infrastructure, the activities, departments, and programs. And again, it's partly based on a collection of all the case studies. I view the learning healthcare system, when fully developed, as equivalent to a 52-card deck. And most of the published case studies are 4 cards, 6 cards, 8 cards. It's a hand. It's part of the deck. We need the entire deck. So again, the idea is the learning healthcare system concepts are valuable but underdeveloped and incomplete, and we should be focusing some time and effort trying to better understand what that system would look like and how to get there. So last concept, again, of a long list of different areas of activity that I think will move our field forward, is the concept of enhanced harmonization and coordination in coordinating centers. And my own interest in this issue came from some frustrating experiences as the PI of a coordinated study, where I was asked to join conference calls and to participate with 3 or 4 parallel studies in efforts to harmonize. And the effort devolved to the point where a lot of us sort of felt that we were being asked to join a conference call once a month to sit around and chat. there wasn't much direction, much focus, much of a mission or set of goals. And so I began to think a little bit with colleagues about what does it take to effectively harmonize and coordinate studies in the realm of complex health interventions. And the answer, as with just about everything else in our research, is not at all the same as what it takes to effectively coordinate a set of vaccine studies. One simple example, if you are one of 5 studies evaluating a vaccine, you of course harmonize the outcomes and the measures. Oftentimes you actually delegate responsibility for data collection to a coordinating center. So that's an important focus or target of harmonization. You don't harmonize the vaccine. It comes to the factory pre-harmonized. Everybody gets the same vaccine. But again, let's go back to the case of the 5 implementation studies within Department of Veterans Affairs. No matter how hard we try to develop some sort of core function form matrix in some protocol for the implementation bundle, we know that it's going to play out differently at every single site. And more often than not, when you have a portfolio of 5 or 6 studies in a given area, each team is responsible for developing its own intervention. So you don't have any attempt at harmonization at all. What that means is, again, at the end of the day, 5 separate publications of 5 very heterogeneous, very diverse implementation bundles or health promotion programs, 5 different sets of terms, language, concepts, different patterns of documentation. And again, it's nearly impossible for any reader to reconcile and make sense of that body of work and try to figure out what to do. So again, that's one example of how harmonization and coordination for complex health intervention research need to be different from coordination for simple intervention research. So we started to think about what does it mean to effectively coordinate a portfolio of studies in some realm of complex health interventions. And we started with the ultimate right-hand side, which is value, or the opposite of waste in research. Read the Lancet series on waste, a lot of other publications, a lot of work, as you know, been done on research impact analysis. So there's a lot of guidance to what makes for high quality, effective, valuable research. And then we backed up from that and determined that in order for research to be value, it has to pursue important questions. It has to be conducted in a way that is valid. It has to be cumulative. Separate studies that throw out random data points that aren't easily synthesized don't lead to much societal value. We have to have our studies designed and conducted in a way and followed up in a way that leads to cumulative knowledge. We also have to ensure that the research is disseminated and followed up properly. It's not enough simply to publish, but we need to follow up on our research. One of the efforts I'm involved in with a couple of fellows is to flesh out the concept of a follow-up plan. Basically, a counterpoint to what is too often a requirement for us to specify or include in our grant applications a dissemination implementation plan. And the way that I like to think about it is if you take 50 VA grants and you extract the dissemination implementation plan page, throw them down the stairs and mix them up, you're not going to tell when you put them back together. Everybody includes the same dissemination implementation plan. Despite the fact that some of our research is early pilot developmental work for which dissemination is always appropriate, but implementation or dissemination of policy practice leaders is premature. Whereas other studies are more of a so-called definitive study for which the appropriate follow-up is policy and practice adoption. Although in some cases, the appropriate follow-up is changes in regulations because the finding itself is not likely to be implementable absent regulatory change. So the goal of the concept of a follow-up plan is to think hard about any given piece of research and determine exactly what needs to happen the next day in order for that research to move along towards the ultimate goal of societal impact. And that follow-up plan has to be highly tailored to the characteristics of not only the study, but other research that exists. So anyway, the point is that in the case of research value, appropriate dissemination follow-up is one key element. And then there's the issue of value. And actually, as we're thinking about our large grant application, the study coordinating centers can conduct a national survey we realize that in the current political climate, emphasizing the value piece is quite important. Because a coordinating center has the ability to take on delegated responsibility for certain tasks that otherwise would be replicated in an inefficient manner by each individual study. You know, when I talk about what NIH should do with the funds that would allow them to fund 5 projects, each of which at $500,000 a year, and that in my view, they should probably fund only 4 projects and take the remaining $500,000 for a coordinating center, maybe we don't have to do that. Maybe we take those 5 projects and instead of a $500,000 each gets 400,000. That leaves the $500,000 for the coordinating center. And if the coordinating center takes on $100,000 worth of work, offloading it from each of those projects, everybody ends up better. So the idea that researchers don't like to be coordinated because we all know how to design and conduct our studies and we'd like to go in our corner and do things on our own. That's one area of resistance to better coordination. But the idea that the coordination is expensive does have a solution, again, if we are able to offload and make research more efficient. But our hope is that sort of touting the efficiency aspects of coordination would make this grant application a little bit more fundable. I won't spend any time because I've gone over the amount of time that I wanted to spend talking rather than discussing, but you know, the bottom line is that as with many other aspects of research, the needs for harmonization and coordination in the implementation science field are not the same as the needs and requirements for coordination for simple intervention research, for drug trials, vaccine trials. And we need to think about that, and we need to shift the kinds of activities and the ways that we go about establishing and conducting harmonization. So let me stop there and open up for discussion, comments, questions. Again, with the idea that I touched on several somewhat random topics and would love to discuss further with anyone who has any interest, comments, criticisms on any of these topics. Thank you.
Thanks very much, Brian. Before we get to the discussion, we already have a good question in the chat. Just wanted to announce 2 things. One is that Brian mentioned practice-based research networks, and Wednesday we have another talk. Katrina Donahue is coming to town, and she's done a lot of practice-based network research, and she'll be talking about that. So I think that'll be a nice follow-up. The other thing I neglected to mention in my introduction is that part of the reason we're lucky enough to have Brian in town is that Brian and Debbie are here in town for their son Ben's dissertation defense at 1 p.m. today. I have that on my calendar. I didn't write down the title, but it has something to do with artificial intelligence and thromboembolic defense. Is that right?
That's as much as I know. Debbie may know.
Anyway, it looked really interesting. So 1 o'clock today. We have the first question we have in the chat is how to measure the success of dissemination of research findings. And she has a couple of comments, but how would you measure success?
So, I think that this gets back, in my view, to the issue of a follow-up plan, in that it has to be sort of custom design, fit for purpose. Because the success of dissemination of a pilot study, where the appropriate next step is more research is needed, is awareness on the part of other researchers in the field and funding agency representatives, their awareness of those findings and their awareness of what needs to happen in order to keep the ball rolling. If it is a so-called definitive study where there are no regulatory or fiscal barriers, and the only thing stopping us from full societal benefit from that piece of research is health system leaders' knowledge and efforts to implement, then success is their awareness and their implementation efforts. But again, the requirements for full value of any piece of research are heterogeneous, and we need to think harder about what needs to be done the day after, the week after, the year after.
By the way, if you stand about here, they'll be able to
Okay.
see you. It's very near. And for those in the room, it looks like we have a couple speakers in the ceiling, so show toward the ceiling. Hopefully people can hear online. If you can't hear online, please put it in the chat. Any comments? Yeah.
Maybe as one of the non-researchers in the room, I guess my question is really, why don't researchers look at the process? So you're looking at the inputs, you're looking at the outputs. Is it the IRB? Is it the system that is blinding them from the process? What do you?
Yeah,
think
so
is
I'll give you
best?
my suggestion, but then hope that Dave, Kurt and Mary have other thoughts. We all grew up learning how to do research in medical schools where, the gold standard is the RCT. There are textbooks, courses, and lots of good guidance on how you design and conduct simple RCTs. And the fact that the word gold standard is applied says something about the research community's assessment and belief in the value of that approach. None of us like to or are comfortable with, and I shouldn't say none of us, many of us are not comfortable with these more complicated methods. Trying to understand mediation analysis, trying to understand how to combine qualitative process evaluation, insights into the results of a trial. And it's just not as easy and straightforward. And journals, unfortunately, like very elegant, sometimes if I'm in a critical mode, I will describe many clinical trial reports as elegant pieces of literature. When they're evaluating drugs and vaccines, they're highly useful. So they both add value in addition to elegant. Many of the results of clinical trials of complex health interventions, I think, fall under the elegant literature, but relatively little value. If all they do is tell you that this particular version of a complex health intervention was highly effective at this point in time in this particular set of sites with the leaders and the staff and everything else that occurred and were in place at that point. The fact that there's no other scenario or context like that, and that when you try to deploy that same program anywhere else, you're likely to see very different results, is not necessarily recognized in that elegant piece of literature. But Dave, Mary, Kurt, other thoughts?
Well, first, number one, it's really hard.
Sure.
Number two, it's not valued by them who are paying to do the research. Turns out though, that basic science is a lot more like this than you think.
Mhm.
When I started as a basic scientist at a lab for 15 years. And I remember when I started, my immediate supervisor was a PhD. And he told me to do this process and get a feel for it. And I had no clue what he was talking about. Get a feel for it. I'll follow the protocol. A, B, C, D. Not at all. But if you read scientific papers, they're literature books. But they leave out all the getting a feel for it stuff. Because it's really hard. And every place is a little bit different. Really good. There's an interesting paper by William Sternberg that recently came out about the embeddedness of all problems.
Mhm.
And yet we as researchers are trying to do everything we can to either get rid of context if we possibly can, or ignore it if we can't. But that's just not the reality.
Could I follow up on that? Because when Brian was talking, I remembered what the conference was about where we met. It was this nice little conference center, but 15 of us, and Larry Green and Russ Glasgow got us new journal editors into the room and asked us to try to develop a consort-like checklist for external validity. And we struggled for 2.5 days and failed. And I took that as a real challenge. I spent the next 5 years struggling and failing at that. But I did come up with a bit of a checklist of things to pay attention to. And it really is, as Brian talked about, multi-level effects. Look at these multiple levels of these things that might be affecting what happens and why and for whom it matters, and pay attention to that. And do that before and in the middle and at the end, and look at that time variant. And then I had an opportunity to try that out. ARC had funded 14 centers. They didn't really have a coordinating center, but the funder brought them together multiple times, and they were going to publish a supplement on the main effects from these 14 intervention studies in practice-based research networks. Actually, Katrina Donahue was one of the investigators. And I was the journal editor who's going to publish that. And I said, can I ask them to do something? Can I kind of make them do something? They said yes. So I said, what I'd like you all to do is write your papers up the way you would normally write them up, and then use this checklist. And this was early on enough, and pay attention to these things. I'll give you an extra 500 words in the paper and have as much space as you want in this appendix, and look at what happened and why, for whom mattered, and look at all the contextual factors and all the tailoring that happened along the way. And then as a journal editor, I read these papers. They were good papers. I liked them. And I thought I understood in a couple of them, including Katrina's paper. I said, wow, I want to do this where I am. And then I read the appendices and said, oh, I can't do this. Katrina's intervention, I thought I could transport that to where I was. Her intervention was based on 20 years of investment in relationships in the AHEX across the state of North Carolina. I didn't have that. If I tried to do her narrow intervention, it would fail. So I had a question there too, but I think I lost it. Anyway, but the idea that context matters seems really important.
So just a couple of images, Laura, that I would add to all of this. So first of all, I view us as researchers as unfortunately sometimes akin to the drunk looking for the keys under the lamppost. We look there because it's easy and the light is there. You know, they were lost all, you know, in the dark, scary end of the alley, but no one wants to go there. So that's at least one image. The other, well, it'll come back to me, but you know, again, I think the idea is that, you know, it's very hard. So there is one other thought, and that is, you know, building on what Kurt just said. You know, if we imagine a, you know, academic, you know, speaking to a group of health system leaders or clinical leaders about a new intervention, and we're talking about an implementation bundle or a health promotion program. Oftentimes, the response to a presentation of the amazing results that were achieved at Cedars-Sinai in West LA or UCLA or another, you know, academic setting is, you know, the clinicians will say, you know, congratulations, you know, amazing results. But as you know, I can't replicate that because I'm missing some of the key features that you have. What should I do? And the answer is often, I don't know, because they didn't think about it. The other answer is often, you know, I could replicate that if you'd like me to. We have the ability to follow your manualized intervention. But I can tell you up front, even before we do anything, it's not going to work for us because our needs are different. So recognizing those two types of responses to an effort to spread any sort of complex health intervention, and ensuring that the designers and the researchers evaluating it recognize that and plan for it in advance. You know, oftentimes there may be some opportunities for us when we develop a program at Kaiser in Southern California, which, you know, again, is highly resourced, you know, has lots and lots of advantages that most other places don't. There might be some opportunities for us to tweak our intervention in a few ways that might lead to some minor loss of effectiveness, but with a significant improvement in expansion in its relevance. Those are the kinds of you know, ideas that come from the kind of stakeholder engagement process or advisory board that I was talking about. You know, we rarely have ever conducted a study at Kaiser without an advisory board that consists of representatives from some of the key target audiences. So they can tell us along the way, this will work for us, this won't work for us. Have you thought about this minor revision? So thinking about, and that comes directly from the external validity meeting, and you know, that was probably my, you know, major sort of eye-opening experience in understanding this issue of heterogeneity and the need for adaptability. And again, you know, the core function form framework is a powerful tool to allow this to happen. Everybody needs to have the same core functions. And in this case, you know, it's quite possible that the AHEX and those relationships can be described as some underlying core function, for which there are other forms, other ways of trying to replicate some of that, you know, set of connections that may not take 20 years. So, you know, one way of thinking about it is, as a health system leader, don't tell me what to do, tell me what I'm trying to achieve. And give me a menu of ways that I can achieve it. So again, it's not 20 minutes of walking, it's 20 minutes of exercise. It's not, a physician brief intervention, it's patient education. And the strategy for effective patient education in some cases is not a physician brief intervention. We know that for vaccine hesitancy, for many communities, having the physicians advocate for the vaccine is counterproductive. It sort of reinforces this belief that the physicians are in the pocketbooks of the evil pharmaceutical companies, and you want peer education. In other cases, though, physician brief interventions can be highly effective. So distinguishing between the core functions of forms and focusing our research on the core functions, not the forms, is one part of the solution to make our research more relevant and more useful.
Wonderful. And one of the questions in the chat actually was about those core functions. I'll move on to another one from Srinivas Samaragu, who actually runs the Institute for Hope at our local metro health system. He talks about behavioral economics and organizational psychology as being valuable. And he says, I'm curious if you'd agree with some of these statements that he makes and how you see organizations doing this effectively. So let me go back to his statements. One is about the effectiveness of behavioral economics and organizational psychology. It says the skills and expertise of those who lead CHI.
Complex health interventions?
Thank you. May be substantially different than those who lead work on other ends of the spectrums, basic science, QI. It says implementation tends to be highly relationship driven, involves more involvement in organizational politics, influence, and power.
Sure. Yeah, no, I think the distinction between tacit knowledge and explicit knowledge is critically important. To be an effective health system leader, to be an effective health promotion advocate or public health agency leader, I agree, is a lot of it is relationship. It's one parallel is the idea of teaching leadership. Okay. Somewhat oversimplified, but one of the key findings from decades of research on leadership is that on average leaders are tall. Exactly what personality characteristics, what cognitive skills, what behaviors are needed, or let's think about something closer to home for many of us, and that is child raising. I think there is a fair amount of empirical research on how to raise a successful independent kid. And you know that in some cases, very clear, explicit discipline and limitations are important. In other cases, it's the opposite. So, highly heterogeneous, highly contingent. And leadership, child rearing, those are not easy skills to teach. We can do research, we can identify some of the factors, so to me, the goal is to understand and impart leaders with the ability to monitor the effects of their actions and to respond. And it's another version of the iterative rapid cycle improvement. We don't know what's likely to work. The best way to know what's likely to work is to actually try it. And if it works, it works. If it doesn't, you have to do something different. So to raise a child effectively, to lead an organization effectively, to deploy a health promotion program effectively is not the same as, clinical trial of a vaccine, where you deploy the vaccine in 6 weeks or 6 months later, you come back and measure. You have to be measuring early and often. You have to have the skill, which is some tacit knowledge, as well as the explicit knowledge to understand and observe and monitor the effects and to know what to do to respond and to iterate in order to try to move, through cycles upwards towards higher performance.
I love bringing together child rearing and leadership. Other comments or questions?
So as a Canadian and American, I find it really interesting how American health policy research is often used as a tool to learn from, to implement interventions in systems that look completely different than the American, right? So in this case, what I'm finding really interesting is, so we want to have a multifactorial, multi-interventionist approach, right? A combination of probably multiple interventions in a system where let's try it, and if it doesn't work, we learn from it. However, I'm thinking of, let's say it's in like Canada, where it's completely, paid for. In that kind of a situation where a policymaker wants to solve a problem, let's say longer wait time. And now, if we're gonna use your approach, we design a multi-interventionist model and think about at a systems level, a provider level, at a patient level. But I guess I have a two-pronged question. One is, how does one make the cost effectiveness case prior to implementing the intervention as a selling point to the politicians who will pay for it? And two, in that kind of a situation, it's almost like you can't fail, because then the public goes against you and then you'll never be able to change it. Which causes the really, terrible conundrum. I'm wondering, can you think of, or, what kind of advice would you give a policymaker in that kind of a situation?
So this is actually one of the examples where we should be borrowing and adapting, stealing from our clinical trial colleagues, and that is the FDA 4-phase model for drug development and evaluation. Too often in implementation improvement, complex health interventions, we jump immediately to a relatively large definitive trial. And I for a long time was criticizing ARC because it funded a set of studies in behavioral economics that were 5-year, $5 million large trials. And I'm probably getting the numbers wrong, but the idea was that, they jumped very quickly to these definitive trials, completely ignoring the need for the phase 1 pilot work. And we actually had this experience in the query program, in the very beginning of the VA's Quality Enhancement Research Initiative. Those of you who were involved may remember that each of the query centers was given the requirement to conduct an 18-month study to demonstrate successful implementation. A lot riding on it because it was a major shift in VA policy, taking clinical dollars and sending them to the researchers. Without exception, those 18-month studies did not succeed in showing improvement. And one of the reasons was, and in many cases, they realized that things were not going very well during the first 18 days or 8 weeks or so. But these were good, high quality researchers who were conducting clinical trials based on very rigorous protocols that were well developed with a focus on internal validity. So you had to let the protocol play out. The point is, again, back to this issue of complexity and need for us to learn while doing. If we begin that kind of work with a 6-month pilot that's relatively quick and dirty and inexpensive, we can learn 90% of the lessons that we would have learned in that 18-month study very quickly and adapt to it. So trying to gather as much information as we can as quickly and easily as possible, and then continually sort of revising our plans. And if it's based on a solid idea, and if it's based on prior evidence, which most of the work that we do is, we're never sitting down with a blank slate. We're compiling and combining ideas that have worked in the past. But the combinations and the application to a new problem is what's new and different. So we can move in an iterative manner and not commit ourselves to something for which, if there is a major problem, it's too late to do anything about it. Another way that I think about this is, and this applies to the Medicare demonstration program, what used to be the Medicare large demonstration projects. Many of those 5-year, in their case, often $50 million projects, led to a finding of no effect. The answer that, or the conclusion that one would reach if one were a clinical researcher evaluating in a $2 billion, clinical trial of a vaccine, the conclusion is that didn't work, let's try something else. It's not the conclusion we should be reaching. The conclusion should be that didn't work quite as well as we wanted, although it did work in some cases, not in others. Let's understand why it didn't work, and let's figure out what to do about it to make it work better. Don Berwick had written an editorial on this a number of years ago. The title, I think, had something, the phrase, "the stories beneath." The idea that most complex health interventions, this is true of the WHO surgical checklist study as well. If you take a look at the results of that study, the average, the top line result is this is effective. Actually does a very good job of hiding the stories beneath, which is that 1 or 2 sites showed very significant improvement. The other sites showed no improvement or possibly even some harm. And again, I may be getting the details wrong, but the general idea I think is accurate. If I'm a health system leader and you tell me that on average, I will do better by deploying this highly disruptive intervention because 3 sites showed significant improvement and 10 sites showed no change. It's not a very good plan, So the idea again is that for us, average effect size estimates don't make sense. It's rare for us to find something that is completely ineffective. Usually there are sites that did well and others that didn't. And as with the histograms that I showed, the answer is not, is this effective? The question is, which sites did well, which didn't, and how can we move things? So again, the 4-phase approach and an iterative model that may include 5 or 10 phases is, I think, a way of avoiding the situation where it's a big failure.
I have 2 related questions. One is, just throw everything at an intervention. I wonder if one of the reasons that works is that there's some built-in tailoring. So everybody doesn't do everything to the same degree, and then they can select. It's actually empowering people on the front lines. And then for understanding that and what works for whom and what situation and why, I think you mentioned mixed methods. And so I wonder about having some narratives to go with the numbers is a helpful strategy.
Yeah, to me, the goal of this kind of research should be to get a better understanding of how the world works. I think that all of these studies should begin and end with a very clear causal model that we lay out as a diagram that shows how A causes B causes C, and the moderators that affect the strength of those relationships, the various intermediate outcomes and the mediators and so on. And as a health system leader, the numbers to me, again, probably shouldn't matter. Because the fact that someone saw a 35% improvement doesn't mean that I'll see anything like that. What is important is for me to understand, the mousetrap contraption and how it works. And if you can give me insight through your research into which of those causal relationships seems to be more important, I can then add my own tacit knowledge about my system and my own knowledge about what form of engagement will overcome this particular barrier. So again, the output of our research should be not as much, the overall effect size, but instead very deep insights into mechanisms of effect depicted by some visual diagram. And that we use both qualitative as well as quantitative research in order to, develop and refine that diagram. When you think about trying to synthesize the results of my, 5 studies of a given implementation bundle, how do you synthesize the results when the output is a causal diagram with coefficients on all the different paths? So even that task of cumulative knowledge is different and challenging for us. But a single number, or even set of numbers, doesn't capture the output in the same way that these, basic implicit knowledge of how the world works, documented in a diagram would capture what I've learned.
Yeah, I have a question. This has been really a great presentation and had me thinking in so many different ways, but I'm very intrigued with the Learning Healthcare System Handbook.
Sure.
I'm on a Clinical Translational Science Award national group, and they're talking about learning healthcare systems. And there seems to be a lot of confusion, so I think this is going to be a great advantage to it. And when we talked, it almost seemed like they were ignoring all the history of quality improvement. And I hear a lot of quality improvement language in what you're saying, the operations component of what we're doing, you're just kind of going from it. So I have 2 questions. One is, do you think that, what are you putting in the handbook on capacity building? I know Corey had that as their first step in their recent funding across the things. And secondly, I wondered if you would propose that we have a different kind of literature review for studies in complex health interventions.
So let me take the learning health system idea first. So the way that we're setting up the handbook is, again, it's based on a core function form sort of concept. That to be a learning healthcare system, and I distinguish as many of us do, although not all, between the learning health system concept, which applies to a region or a country, as an overall society organized as a learning health system versus a healthcare delivery system like Kaiser. So to me, a learning healthcare system is an integrated delivery system that operates in this way. But the idea is to identify the core functions. In order to learn, you have to, first of all, have robust comprehensive performance monitoring. You have to know where, in what areas your health system is not doing as well as the industry leaders, but you also have to know where you're not doing as well as you'd like to. So areas where the mortality rates are high, even if you're doing better than everyone else, are a good focus for research and innovation. Areas where you may be doing, your mortality rate may be low, but the industry leaders are even lower. Those again are a focus. So, none of our systems have the capacity and the resources to do everything all at once. So some sort of monitoring, benchmarking, and prioritization is one of the key core functions. Internal innovation and research and evaluation expertise, as well as environmental scanning, because a lot of the solutions to some of our performance problems that we've prioritized, readmission rates or whatever the case may be, they're good solutions out in the literature. So one of the core functions is that environmental scanning. But you also have to have capacity, and core functions related to vetting and tailoring and evaluation. You have to have core functions and activities related to sustainment and scale up and spread across your system. So the core functions are the programs or departments or activities that you need to have in place, all of which have lists of enabling conditions, which are the capacity, the capabilities, the infrastructure. So that's a separate part of the handbook that says what you as a healthcare system leader need to have in place and readily available in order to carry out the core functions that are the core elements of being a learning health system. One other comment on learning health system literature, and one of the gaps, is most of the published work, as you know, the attention and thinking, is focused on one of the two key elements of the learning health system concept, and that is knowledge and evidence development. So, oversimplifying somewhat, a learning health system or a learning healthcare system uses data that were produced by and for care delivery for the purpose of learning and research and innovation. And that's, again, what a lot of literature focuses on. The other half of the concept, though, is rapid implementation of the results of that. And there's not nearly as much written. So I think the implementation science field has both a lot to contribute, but also a lot to benefit from learning healthcare system ideas. I'm very interested in the 70-year problems, I call it, where each time we confront a new implementation gap in a system like Kaiser, we apply the well-established implementation science framework. So we spend a couple of years studying current practices and identifying the root causes of the gaps. Then we spend a couple of years with our pilot implementation studies, then a couple of years in the efficacy-oriented studies, where the research team is actively involved in delivering the implementation bundle. Then we move to the effectiveness phase, where the research team steps back and allows the health system leaders to deploy the program. And then we get into the post-marketing phase, where we continue to evaluate it. We can't take that bottom-up, problem-by-problem approach to every single implementation or quality gap. What if there was a way of redesigning healthcare systems so that we could do top-down implementation? So if clinical care were guided by a written protocol or checklist or flow diagram, and new evidence suggested that we insert a new clinical activity at some point. And one of the examples from work I did with colleagues at Kaiser is bladder cancer resection, where if you infuse chemotherapy in the bladder after you resect the tumor, you can eliminate a lot of the microscopic cells that are released and would cause a recurrence. So that's a new evidence-based practice that needs to be inserted into the standard process for surgical treatment of bladder cancer. If that process followed a flow diagram or a protocol, the implementation process would essentially be 5 minutes of word processing. I would edit that document and I would add that step. Instead of doing what we did, which is spent months and months conducting interviews, trying to understand why this new evidence-based practice wasn't followed consistently, followed by months and months of implementation efforts to try to get the surgeons to do things differently. So, obviously that's an oversimplification, and there are lots of reasons why, lots of barriers to that practice change. But the point is thinking about the way that we deliver healthcare and thinking about organization design, and whether we can design organizations to implement more rapidly in a top-down way rather than bottom-up.
So we'll take a question from David in the room. I've been sitting on one high-level policy question, and then we'll, on the chat, and then we'll.
So I wanted to give a really good example of top-down implementation.
Okay.
That really worked well. It occurred during World War II. In the first 2 years of the war, the U.S. Navy lost most of the battle. And Chester Nimitz, who was the head of the Navy in the Pacific, saw that there were some ships that were more successful than others. And there was one particular historian that was really successful. And he was getting reports of what this one had done. He basically invented the Combat Information Center, where all the information would go to one officer who would then go to the captain rather than have everything go. Nimitz saw this, mandated.
That's a concept that we're actually working on. We have an article that's in press, but we're hoping that we have a chance to maybe change a couple of terms, maybe even the title. We facilitated practice substitution within Kaiser Permanente for cervical cancer screening. We eliminated pap smears, and we're now relying exclusively on HPV testing. We went through lots and lots of brainstorming to try to figure out what the implementation strategy would be to, successfully and quickly get the physicians to change their practice. And at some point, someone said, you know what? We're going to change the EHR ordering stream, and we're going to eliminate the outdated practice as our de-implementation strategy. And they're only going to have one option, and that is HPV testing. There were some exceptions, but we're thinking through whether we should call that forced implementation, mandated implementation, constrained choice implementation. But the idea is to think about this example of a top-down method, where again, the implementation can be overnight. And what are the kinds of practice changes through which that's appropriate? Because it's not a good idea. And what are the implications for implementation science? We had a 95, 98% implementation rate. There was no difference in the main study aim, which was a comparison between local tailoring and consistent system-wide. Everybody implemented completely. What is interesting is the secondary outcomes, such as physician satisfaction and response. If you mandate change, then maybe you have to think about the fourth aim in the quintuple aim, the quadruple aim. So again, it's a different way of thinking about implementation science, but thinking through the different categories of implementation strategies with a focus on that forced, mandated, constrained choice is what we're dealing with right now.
We're about at time, but last question from the chat here is, how are healthcare systems raising their concerns about drastic cuts in HHS funding?
Ours is doing so very quietly because nobody wants to stick their neck up and be viewed as a target. With the idea that they'll have to deal with it when the time comes. But what I've heard though is that both in our research program, well, the research program is slightly different, but in the health system, the basic idea is to wait and see. In research, of course, we're trying to diversify. And our research program is a little bit better than many of our academic colleagues because our mix of funding across foundations, industry, government is a little bit more diversified. But I know I'm spending a lot of my own time on the phone with colleagues in industry. Proven implementation science, by the way, is sort of the next frontier. Drug companies for a long time have had basis science and clinical research. 10, 15, 20 years ago, they began to discover outcomes, real world evidence, effectiveness studies, pharmacoeconomics. So most drug companies now have research programs in that field. More of them are now discovering implementation science and setting up implementation science teams and programs. And I'm actively trying to develop an inventory and work with them to see if we can accelerate that trend. So again, a topic for which anyone interested, please get in touch with me and I'll get you up to speed and see what you could do to help out.
many compliments in the chat, as well as links to Ben's dissertation, to Peter Donahue's presentation Wednesday, and actually to the star tables. Dr. Mittman, thank you very much. I really appreciate it. And also,
Always worried when who's going to scatter. Whether it's.
Brian, it was different.
That's multifactorial.
Rome is 2002.
Well,
Thank you.
nice validation. Okay.